Inspectra STO2 is a non-invasive, cost-effective measurement that rapidly assesses tissue perfusion status of at-risk patients. It helps clinicians assess and treat critically ill patients from the pre-hospital period through hospital admission. Because it's essential to rapidly identify hypoperfusion and track the effectiveness of resuscitation efforts, Hutchinson Technology offers two devices. The Inspectra STO2 Spot Check is designed to be portable and low cost per patient, making it perfectly suited as a screening and initial assessment tool for identifying hypoperfusion. The Inspectra STO2 monitor provides a continuous trend to gauge the effectiveness of medical interventions in hypoperfused patients. Next, you'll learn about microcirculatory tissue oxygen saturation and the Inspectra STO2 reading.
Hi, I'm Tom Ahrens. I'm a research scientist in critical care, and I've been involved in tissue oxygenation monitoring for much of my career. Now we're going to discuss a little bit about STO2. What is STO2 monitoring? Well, STO2 measures the hemoglobin oxygen saturation of blood in the microcirculation, specifically the arterioles, the capillaries, and the venules. The microcirculation is where oxygen diffuses to tissue cells. Therefore, STO2 is a direct measure of tissue oxygenation and reflects the balance between oxygen delivered to the microcirculation and oxygen consumed by tissue cells. In clinical studies, STO2 was shown to be a sensitive indicator of tissue perfusion status. Now, are there any other non-invasive methods available for determining tissue oxygenation saturation? Unfortunately, no. Near-infrared spectroscopy is the only non-invasive method for measuring oxygen saturation at the tissue level. Pulse oximeters, which are often thought to measure tissue oxygenation, actually do not. Pulse oximeters measure arterial oxygen saturation and indicate how well oxygen is loaded onto hemoglobin in the lungs. They tell you how much oxygen is available to tissue cells, but not whether oxygen actually reaches or is consumed by tissue cells. Now, another way to look at tissue oxygenation is venous oxygen saturation, and that is either measured via a catheter placed in the superior vena cava, called the SCVO2, or the pulmonary artery, which is called the SVO2. With both these methods, there is significant potential for delayed detection of decreases or drops in venous saturation secondary to the mixing of blood from the brain and heart, organs that are selectively protected in shock states. In addition, these measurements require invasive catheters, and the resources required for catheter placement and calibration have limited the application of both these techniques. Now, there are metabolic markers of tissue perfusion status, such as lactate and base deficit, but these are intermittent and require blood samples, and they're not real-time measures of tissue perfusion because they take time to accumulate and clear from the blood. In contrast, STO2 offers the advantage of being continuous, real-time, and non-invasive. Now, STO2 is measured in the thenar eminence, a group of muscles at the base of the thumb. This may seem like an unusual place to measure tissue oxygenation until you consider the redistribution of blood flow that occurs during shock. During shock, blood flow to peripheral muscles and even some core organs like the liver, gut, and kidneys is reduced or diverted to the brain and heart to preserve oxygen delivery. The thenar muscle group is an easily accessible peripheral muscle bed. Now, the STO2 measured in the thenar muscle allows for non-invasive monitoring of early changes in peripheral perfusion status during both shock and resuscitation. In addition, the thenar site has been shown to be minimally affected by age, gender, edema, and adipose or fat tissue. It's also been shown that STO2 is not confounded by hypothermia. Unlike a pulse oximeter, measuring STO2 does not require a pulse. STO2 can be accurately measured in pulseless and hypothermic patients. These conditions are especially of interest in trauma patients and in patients who therapeutic hypothermia is being implemented. Both the spot check and the monitor use near-infrared light to illuminate tissue beneath the sensor. This light scatters in the tissue and is absorbed by hemoglobin. The amount of light absorbed varies depending on the oxidation state of hemoglobin. By measuring the light that returns to the spectrometer, the system is able to calculate and display tissue oxygen saturation, or the StO2 of muscle tissue. It is important to consider both the current StO2 value and the trend when assessing patient status. For example, if the StO2 values are persistently below 75%, then we need to assess a patient for evidence of hypoperfusion. But first, check the arm on which the sensor is placed to rule out anything that could restrict blood flow, such as an inflated blood pressure cuff, a bandage encircling the arm, or a clenched fist. Then consider the following physiologic global factors that can influence oxygen delivery to the tissues. The three key things are cardiac output, hemoglobin, and oxygen saturation. Now, if resuscitation interventions are effective in improving tissue perfusion and oxygenation, the StO2 will increase. The need for continued resuscitation should be assessed, and discontinuing resuscitation should be considered as the StO2 crosses the 75% threshold. A falling StO2 strongly suggests abnormal or deteriorating perfusion status and should prompt a thorough investigation into possible causes, such as a new hemorrhage. Now, StO2 values in the mid to high 90s are most often seen in patients with very high oxygen delivery. This is commonly seen in patients who are systemically vasodilated and have high cardiac outputs. An expected clinical range for StO2 in patients is approximately 75% to maybe even as high as the low 90s. Low StO2 readings have been shown to be associated with poor outcomes and should be investigated. A reading below 75% is a red flag that the patient might be hypoperfused and warrants further investigation. As previously noted, studies have shown that low StO2 is associated with poor outcomes such as organ failure and higher mortality rates. This means StO2 can be readily used to help identify patients who are at risk of bad outcomes. Now, recent clinical studies in critically ill patients found that low StO2 occurs frequently. Ardolik and colleagues demonstrated that 20% of treated emergency department patients waiting to be admitted to a medical floor had StO2 readings less than 75%. In the Netherlands, Venning measured StO2 in ICU patients considered to be resuscitated, and yet found a similar instance of low StO2 readings. Importantly, a study of patients presenting to the emergency department in shock demonstrated that StO2-guided resuscitation resulted in a shorter hospital length of stay. Now, monitoring StO2 can be easily incorporated into protocols to help risk stratify patients and track resuscitation. Emergency room and in-hospital critical care patients who are most likely to benefit from StO2 monitoring are high acuity patients, those who are 65 years and older, trauma patients, and patients at risk for medical bleeding. I hope this short presentation was helpful to you in understanding how to use StO2 monitoring. And here are the references used for this discussion.